it is tricky. So exam three is tricky. You've got to be very careful. You've got to read the questions. There's a lot of questions that will ask you what the parent is doing wrong, not what's doing right. Those sort of questions. Again, math questions, dose versus day, those things, those tricky things are going to be there. All right, let's go ahead and let's start. Said yes, I do make all the PowerPoints. I try to make them as would you look at them? Would you understand what's going on? I think sometimes pictures tell a thousand stories. So I love pictures and I will put them in there for you. So, head injuries in the child. Children are always falling down, always, especially your toddlers, right? There's no fear. There's no filter. They jump off things, landing on their heads. I've actually seen many young toddler preschoolers fall off of second story balconies. They get up on a chair, on a table, and they go over, and they come into the emergency room. The last 10 years of my career was in a trauma center emergency room here in Miami. So, when you have a head injury in a child, the whole thing about it is that damage in the brain. We know one of the things with head injuries in children is when we start seeing that level of consciousness decrease, 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 we're showing swelling that's going on in the brain, and that is dangerous. So, assessing these children is very important. So, when you're watching that child who's fallen down, I mean, I think this picture is great. Somebody fell, they've cut their head. We're concerned. What are we teaching our parent? Well, you're going to tell them to monitor their level of consciousness, right? Also, looking at their pupils. If we see one dilated, fixed pupil not reacting to light, that's a neurological emergency. It's telling me that side of the brain, there's swelling going on, and now it's going to become a big problem and it could be permanent problem. So we need to relieve that. We know that head injuries where the pupils are changing, where the level of consciousness is decreasing, acting confused, asking the same questions over again, or now is walking and is falling over, something's going on in the brain there, right? They also say headaches that wake them up out of a sleep. That is something you need to pay attention to. Now, younger kids, we can control. We can have an R sight. We can wake them up at night, all of that. Well, what about that adolescent, that teenager? What if they have a driver's license and want to drive to school the next day? No, you should not let them because you've had a head injury. We don't know if it's going to progressively get worse or it's going to be okay. So, for safety, we're not going to let them drive until they're cleared by their healthcare provider, their doctor. So, we're change or worsening LOC, mental status, all of those things. Getting restless, can't wake them up. Vomiting is showing a lot of pressure in that brain. As I said, those pupils and a fixed dilated pupil, neurological emergency. We're starting to see double vision, blurred vision, can't see good, can't walk, headache getting worse, wakes them up. This is signs your head injury is getting worse. Now, there's something called traumatic brain injury. And it's when a head hits the floor or hits something and it's like a shock to the brain. In infants, when we're looking at traumatic brain injury, yeah, I put like one of the big absurd pictures here, but that's more of a hydrocephalus. But if we let swelling going on in a brain due to a head injury, it will look like that if we don't take care of it. So with infants, it's great. They've got that beautiful little fontanelle there. That tells us so much about a child. One of the things that will show us head injury with swelling is that fontanelle is now at rest, sitting up, is bulging, not crying, just at rest. Bulging, there's a problem. Also, these scalp veins in the front of the head, they tend to pop. And that's again, pressure's pushing out. It's showing us that. In at late type of increased pressure, remember your brainstem is in the back of the brain. Brainstem controls heart rate, blood pressure, temperature, right? All the basic functions of life. With that swelling going on, it can press on that brain center and it can cause bradycardia. That's when you're in trouble again. Like the dilated pupil, bradycardia, we're getting close to a big problem. Now, you get a child coming in complaining of meningitis type symptoms, or having the headaches, photosensitivity, that meniscus, all those things, right? How do you know how you're going to treat that child? Well, number one, you put them on airborne isolation, whether we know it's viral or bacterial, because we know meningitis can be spread, it's airborne, okay?
I thought it was
Now,
droplet. It's not droplet.
we call it airborne.
Okay, because on the Cahoots also it was a question of what precautions you do, and it was droplet. That was what was
Let,
right.
let me go back and make sure that I'm pretty sure, but I'm not always correct, and I always will check for you. So it is droplet. Absolutely
Okay.
droplet. I've
Okay.
checked it, double checked it. It is droplet. Okay.
Okay.
So
Thank you.
it's in the air, but it's the droplets in the air that get to you, if you think of it that way. Okay. Now,
Okay.
now we got to decide, are we viral or are we bacterial? And the only way to do that is symptoms are the same, virus or bacteria, but we know bacterial is the more dangerous, the one that requires antibiotics, right? The only way to determine that is a lumbar puncture. And the lumbar puncture is going to show us if that cerebral spinal fluid has white blood cells in it, which is showing us infection because white blood cells are infection, and it's going to require antibiotics. They will be on droplet isolation for 24 hours. Okay, because they get the antibiotics in, and then we can open the air up, and then they're going to be safe for everybody else. One of the things with lumbar punctures, make sure that we do have them, just like spinal anything with patients, adults or children, have them lay down flat for a while because they relieved a little bit of pressure out of that cerebral spinal fluid and can cause headaches. So 30 minutes flat. So that child, priority care for a child with meningitis, and that's going to be antibiotics of that bacterial meningitis. Now, if they are a viral meningitis, what's the treatment? Well, what's the treatment for viruses? Rest, fluids, antipyretics. That's it. Okay. Supportive care is viral. When it comes to bacterial, yes, you do all of that other stuff, but you priority is antibiotics, get them in, and it's droplet isolation for the first 24 hours. Remember, their heads hurt. Their heads are just really irritated. So do little cluster cares, minimal stimulation, because of all of that swelling that's going on in their brain. So let's say we have a child now who's fallen and it's got all of this extra fluid in the brain and it's swelling in there, called cerebral edema. Now, if we have fluid in the brain, we can get rid of fluid anywhere in the body. We know that there's diuretics. Well, what is the diuretic to relieve the fluid in the brain? It's mannitol. Furosemide, Lasix, is for peripheral edema or pulmonary edema. Specific to the brain is mannitol, okay? So we need to get that fluid out. And we know that in the care of a child with increased intracranial pressure, you're always going to monitor fluid balance. You don't want to get too much fluid because that's going to create more swelling in the brain. Again, it's a head. What are we monitoring? Change in LOC, lethargy, headache, vomiting, bulging fontanelles. This is all the same. Meningitis, problem with the brain, swelling in the brain, increased pressure, same thing. Hydrocephalus is a condition where that fluid, that cerebral spinal fluid, doesn't know how to go up and down the cerebral spinal tract, and it gets in the brain and it keeps getting swollen, and it gets, increasing fluid into the brain, causing hydrocephalus. Now, hydrocephalus in a child. Now, there's certain things that we will see, and you need to know what these assessments are. So, if you have a child, infants, one of the first assessments we do, I mean, just for every single newborn in newborn ICU, is we do a head circumference every shift. It's part of the assessment. We're looking to see, is there fluid going on in there? The other thing is, and we don't talk really about it in class, is Messawin sign. And sometimes there could be a water in the brain, or it could be some sort of infection in the brain, like an abscess. And we can tell what it is by tapping on the brain. It's called a Messawin sign, okay? So that's part of how we would look for hydrocephalus and assess it in an infant. Also, those sun-setting eyes, I finally found a picture of them where the eyes go down. It's that pressure pushing them down. And of course, any fluid in the brain, increasing pressure, there's going to be vomiting and there's going to be headaches. So many times with hydrocephalus, the body can't take that fluid and move it around. So what we'll do is we'll put in a ventricular peritoneal shunt. Now, this shunt goes into the fourth ventricle, and you actually can see it behind the ear, and there's like a little pump looking thing behind the ear. And that little tube goes now from the brain, draining fluids across the neck, the front of the body, and goes down into the peritoneal cavity. And it just slowly takes out the fluid, decreasing the pressure in the brain. Now, VP shunts in children fail. What happens when your VP shunt fails? Well, fluid starts building up in the brain. What do you think that child's going to feel like? Headache, vomiting. We go to surgery, we go to x-ray, we find the shunt doesn't work, we need a revision or a longer tube, or it disconnected, or whatever it was. We know that post-operatively, this child should not have a headache and should not be vomiting anymore. So we did talk about Wilms tumor. It is part of the GU, but we know that that tumor in the abdomen, like a kidney tumor, can also go and metastasize to the brain, a neuroblastoma, okay? It was one of those pictures that I had with a little baby with a huge abdomen there, knowing that by the time we see the symptoms in the brain, this child, that's the metastasis already. No, how do we treat children with a nephroblastoma? Well, whenever you think of kidneys, think of blood pressure and potassium, right? Blood pressure, you're going to have to monitor because it can affect the blood pressure. That's what kidneys do. Also, with these children, when we're looking about this kidneys, we need to place them on medications for blood pressures. Enalapril, Vasotec. What we use in adults is perfect for these children. So we'll be monitoring blood pressure on them with any kidney problem. If we've had any kidney trauma, you always monitor potassium, because again, potassium, blood pressure, and red blood cells, erythropoietin. Think that's all kidney. All right, those things think about when you hear these things. Now, seizures. Seizures is something can be happen because of any reason, anything at all. I mean, it even could be a glucose problem, too little glucose, fevers, everything could be causing it. So what do we need to know about it? Well, we used to call them grand mal and petit mal. That name is not there no more. They're tonic and clonic, or some sort of absent sort of seizures. Usually when we talk about seizures, we talk about the one that the grand mal, the big seizure. That is the tonic clonic seizure. You're going to see the arms and legs moving and posturing going on. They're going to lose consciousness. They usually will vomit. And, this is something that we need to know how to take care of this child. So if you have a child who has a seizure, you walk into a room. This kid is having a seizure in front of you. It's don't even wonder why or how it happened or what caused it. Your job right then and there is safety for that child. Kids put everything in their beds, right? They've got pencils and pens and scissors and whatever else, what they're playing with. They're all in the bed and on the bedside tables, and it can harm them if they're shaking arms and legs, right? So clear all of that stuff around them. Get rid of any harmful, sharp objects. Side rails up, pat them if you have something to pat them with. Bed flat, take the pillow out and turn them to their side. In case they vomit, you have suction to clear the vomit, not to stick it in their mouth. And if this is going to be a status, which means seizures that just keep going and going and going, this child is going to need an IV and some sort of medications to stop that seizures going on. Now, one of the thing with children with seizures, just like the concussion, we don't let them drive the next day after a concussion until they're cleared. A child with seizures shouldn't be placed in environments that could cause them harm if they have a seizure. Like, what if they're in the middle of a pool and nobody's there, or in the middle of a lake or an ocean? That would be dangerous. So always know that there should be an adult or somebody responsible enough to know the child has a seizure and what to do in case they have a seizure. So pituitary dysfunction, there's two pituitary glands. One has to do with growth and one has to do with fluid. Okay. The anterior is all about growth. Now, many times children are short. Now, if their whole family is short, there's no way we're going to get them taller. So, if we have a child who's short and the rest of the family is of normal stature or tall, this would be a child that would be a good candidate to give them medication daily with a subcutaneous injection every day to increase their height. And we will give them that every day until they stop growing less than 1 inch a year. And that's usually right about puberty, we stop. So it's almost like that you are giving a child insulin every day, isn't it? It's a big commitment. So that's the growth side, the anterior side of the pituitary gland. Now, the posterior side is all about fluid balance. Fluid balances means I am urinating too much or I'm retaining too much, depending on the type that what's going on. So know that fluid balances. How do we know that whatever we're doing, if we're retaining or getting rid of too much fluids, how do we know it works? Well, nursing, intake, output, daily weights. That's how we always look at fluid balance, okay? Now, the posterior pituitary gland fluid balance, what we talk about is diabetes insipidus. Now, this has nothing at all to do with blood sugars. And why they put diabetes there, I don't know. It's there to confuse us. I can't tell you how many nurses, registered nurses of all different level education, would bring me a child with diabetes insipidus and they would tell me what their blood sugar was. And I said, so what's the blood sugar telling me? They go, oh, you have diabetes insipidus. So I took a blood sugar. It's nothing. It has nothing to do with blood sugar. So it has to do with fluid balance. So what happens? They drink, 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 and they urinate, 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 and they're never, never, never satisfied. An infant will drink milk, drink milk, drink milk, drink milk, and urinate and urinate and urinate and still not be satisfied. But give them a bottle of water, all of a sudden they don't cry anymore. It's crazy. I've seen it and it does happen. And, diabetes insipidus is only two signs here. It's polyuria and polydipsia, okay? That's what it is. So, how do we work with diabetes insipidus? So, we have a child who is urinating a lot all of a sudden and thirsty, thirsty, drinking a lot. Polydipsia, polyuria. there is a hormone we can give, and it's called desmopressin, vasopressin, DDAVP, whatever you want to call it. Sometimes it's given nasally, sometimes IV, sub-Q. It depends on the severity of the diabetes insipidus. So when we have a child with diabetes insipidus urinating, drinking, and we give this vasopressin, this DDAVP, how do we know the medication worked? The urine output decreases and they're not as thirsty. It's as simple as that, okay? Remember, this is lifelong. This is not something we cure. We just have to work with it. We know that vasopressin is also used with bedwetting at night. It does work for that too, stops them. And sometimes we have to give that medication to some children. Now, the opposite side of too much drinking and too much urinating is holding on to the urine and fluid retention. And that's the syndrome of inappropriate antidiuretic hormone, which means antidiuretic against urinating, inappropriate, too much against urinating hormone. So if I'm against urinating, I'm not going to urinate. So fluid retention. You're going to see a child who is full of fluid. You, again, how are we going to treat these children? Intake, output, daily weights. We've got to measure what's going on with that fluid there, right? And because they're retaining fluid, you're going to have fluid restrictions and salt restrictions on the child. Now, diabetes mellitus. This is blood sugars, right? So this means that your body is not able to take sugar and use it. So your body's constantly saying, you just ate, but I'm hungry. Where's my food? Let me keep eating. So they're drinking, they're urinating, and that polyphagia, they're hungry because they're not digesting sugar. So the body keeps saying, feed me, feed me. That's the difference between diabetes insipidus and diabetes mellitus. It has to do with the hunger because blood sugars, you don't get enough blood sugar. It goes up in the body, the blood sugar numbers, but it's not being processed, so you're still hungry. So, a hemoglobin A1C. You get these symptoms in a child. They're losing weight, they're just tired, fatigued, they're nauseous. They have the three P's: polyuria, polydipsia, increased hunger, too, right? We're going to go and we're going to do a test, and we do the hemoglobin A1C. Now, a hemoglobin A1C is going to look at blood sugars for the last 3 to 4 months. Now, in adults, they say above 6 is pre-diabetic. 6.5, they call that diabetic. In children, it starts at 7. And their fasting blood sugar is greater than 126. It's 100 for children, for adults. So there is slight difference in the numbers there. So, with this diabetes and all of the symptoms that they're getting, know that adolescents, there's a thing that came up on one of the HESIs, and it was talking about a question, something about an adolescent with a BMI of 92%. Well, if you have an adolescent, older school age child, has a BMI of 92%, they're overweight. So there's many reasons that could happen, but they're also urinating, right? So what could it be? Well, is it diabetes? Is it a urinary tract infection? Is it something else going on with that child? These are things you have to think about. When you get the symptoms, what could it be? Overweight, urinating a lot. It's either a simple UTI or it could be something as diabetes mellitus. So when you have a child who can't process their sugar, the body doesn't like it and it gets hungry, right? It keeps eating, keeps eating, keeps eating. The blood sugar goes higher and higher and higher, but it's still not feeding the body. So the body says, let me eat the fat, let me eat the protein. So the byproduct is ketones. So DKA is hyperglycemia with the presence of a lot of ketones in that body, right? That is DKA. So, what do you see with a child that's in DKA? Well, these kids are pale, they're lethargic, they don't have blood sugar, so they have no energy in them, right? You're also going to smell sugar, and I call it a rotten peach in a Tupperware dish that you left inside a refrigerator for a month. You take it out, open it up, and that sweet, rotten peach smell hits you in the face. That smells like DKA. Exactly like it. I can't describe it any other better way. That's what it is. So you smell it. These kids are going to have decreased level of consciousness. They're not going to feel good. They can barely hold their head up. Sometimes we give too much sugar for some reason, or, you know, we have to understand and teach our parents and our children what is a low blood sugar. Well, when you look at questions that look at low blood sugar, there's one thing you need to look at. Are they awake or are they unconscious? If they're complaining of feeling jittery, nauseous, sweaty, dizzy, vomiting, those things, they're complaining, you can give them something oral. Give them honey, give them a cube of sugar, give them, orange juice, give them milk, give them something with some sugar in it, and that can help increase the blood sugar, help so we can get them out of this hypoglycemic moment, okay? If they're unconscious, you're not putting anything in their mouth. You're going to probably give them a glucagon injection and be prepared. They usually vomit pretty well after they get that glucagon. So have them on their side. So, adrenal issues. Cushing syndrome is usually done by too much steroids. Steroids could be by the own body producing it, the adrenal glands, but usually it's when we're taking oral or IV steroids and it's too much for too long. And the body goes through these changes. So they're getting all of this steroids. They're getting this big round moon face, okay? They're getting little hairs on the chinny chins. This red or ruddy is the same thing as these reddened cheeks of some sort. You're going to see big, pudgy cheeks and trunk, but the arms and the legs are thin because of muscle wasting, protein problems, okay? And because of that protein problems, it's that poor wound healing on these children. And there's going to be a lot of ecchymotic areas due to too much steroids in the body. How do we take care of Cushing syndrome? Well, we taper off the steroids and get them off slowly. I was on bad steroids for a long time and went into Cushing's, and it took me 6 months to get off of steroids the proper way. So that's how severe it is. So the opposite side of Cushing's in the adrenal gland is not enough. Not enough cortisol, not enough aldosterone. And this causes children to be born with ambiguous genitalia, which means you could have, and I've seen one, only one in my whole career, and this child had a prominent clitoris, had a vagina, and had testicles, and they had to decide, what is the child? Is it a boy or a girl? This child is going to have problems with the cortisol, aldosterone, problems with hyponatremia and hyperkalemia. So they really need to be monitored closely, their electrolytes, and they need to be getting cortisol and aldosterone as they need it, as their body desires it. Stress will increase that. So Addison's ambiguous genitalia, and then we have to assign a sex to that child. So hyperthyroidism is when the body produces too much thyroid hormone. This could be also produced the same way if we took too much thyroid medicine. Same things could happen, like thyroid storms, tightness in the chest, elevated heart rate, and hypertension, hyperthermia goes on with these sort of things. So, what we do with Graves until we decide do we need to remove that thyroid or we just calm it down with medications, we do give one called propylthyracil. I don't know how to say the name. I've always called it PTU. It's always been the name on the bottle for me. So PTU is used to stop or block the amount of thyroid hormones given to the body. And one of the things with this medication, it causes leukopenia, means it puts you in an immunosuppressive state, as in you can get infections easily. So this is a child, if we have them on the medication PTU for too much thyroid hormone or hyperthyroidism, they're going to be placed on PTU, and we're going to be watching them for being sick. And if they get sore throats and sick, we need to tell the doctor, is it the medication or is it true and real sickness? So, hypothyroidism. This is one of those things that we would see a meconium ileus. This is one of the symptoms at birth. They don't move stools. And if we didn't know this child had a thyroid problem, that might be the only symptom we saw initially, that there would be no stools in the first 24 to 36 hours. Now, thyroid in children and thyroid and hormone are the same, adults are the same. So children and adults have the same symptoms, except children need the thyroid hormone to grow. So for growth and also cognition development. uh, Adults are already formed. They already have their cognition. They might get a little bit, tired, of course, or mental decline, but in children, we'll see them not meeting their growth and developmental milestones. And that would be telling you that the thyroid hormone's not working well. So, thyroid hormones, how do we give them? Because they're going to have to be given at the same time every day. And because it sort of gives you a boost of energy, because now you're getting what you need to be able to function for the day. It stops that sleepiness and that mental decline. You don't give it in the evening. These children will be awake all night long. It's just like giving them speed at night. You don't do that because it gives them that little boost. Also, thyroid, hypothyroidism has a history of constipation. So, how do you treat constipation? Adult or kid, doesn't matter, right? We're going to increase fluids and increase the fiber in the diet so that they can move their bowels a lot easier. So, there's just a side by side picture that you can see the differences. Now, vomiting in children. Now, whenever I get a young kid into the emergency room, which was my last place I worked, and they are younger than 3 months old, my first question is, they're vomiting. What does it look like? Is it a dribble or is it across the room? And it's going to tell me two different things. Now, if they're just dribbling, a little bit of spits up, little bit of spit up, not projectile like another condition we'll go into in a second. This is a child that will be concerned about dehydration. Know that dehydration in infants, children is extremely dangerous and could cause renal failure, acute renal failure in children. So you don't want a kid to be dehydrated. So how do you look for signs of dehydration in that child who is vomiting? Well, infants, it's great. Let's look at the fontanelle. Is it sunken? We know we got a problem. Once I see a fontanelle that's sunken, I listen for the heart rate. Is it elevated? Well, what is the normal heart rate for an infant? If my heart rate was 200, I know that's too high. Lower blood pressure. If I see a blood pressure, I don't know what it is. For that child, I'm going to ask, right? Or I'm going to look it up. What's the normal blood pressure for a 1 month old or a 1 year old child? Decreased capillary refill, infants crying with no tears. I think that's the saddest thing. And then their skin, if you pull it up, it just tends to stick up there and it doesn't move. That's called skin tenting. So, treatment. You have a child who's vomiting. If they've stopped vomiting, you can give oral rehydration. But if they are continuing vomiting, you don't want to put anything in there so that they keep vomiting. So, what we're going to do is give IV replacement. We'll do a electrolyte profile, right? We want to see where their electrolytes are. And we're going to give a bolus of fluids, no potassium, and no dextrose. If we go to oral, we're just going to give some oral electrolyte solution. Pedialyte, Gatorade, Powerade, one of those is what we need to do. We need to replace the fluid quick because children don't tolerate it. So, if they're vomiting, signs of dehydration, you do that metabolic profile. Let's look at the electrolytes. Start the IV, saline, ringers, whatever the doctor wants. But again, never dextrose, never potassium. We never bolus those things. Okay. The only time we give potassium in an IV to a child is if we have a lab result back or if they vomit, they already voided. If they urinated, we know the kidneys are working and we can give potassium in the IV, but not for a bolus, only for a maintenance. We're going to put them NPO, right? We don't want them vomiting anymore, giving them some sort of antipyretic to stop it. Of course, you'll always have suction at bedside just in case they do vomit, just to prevent aspiration. Now, gastroesophageal reflux or GERD. This is something that can happen in all ages, from infants up to elderly. You know, it's that reflux. Older children will be that chronic cough, that's mini aspirations that they're hearing there, okay? And then abdominal pain and heartburn. That's what it feels like. Now, with infants, very easily, how do we treat it? We put a little bit of rice cereal, 1 teaspoon per ounce, in the formula or breast milk, and it thickens the formula or the milk, and it will hold it down. So that's the first thing we do. Also, we teach these parents you can't overfeed these children. You need to burp them well, and they need to sit up after they eat for a minimum of 30 minutes. Now, older children, the diet has to be bland with no overeating. We don't want anything to upset the stomach. Now, we do every medication an adult does. You start out with simple, the Pepsid or the Zantac type thing, or maybe some Metalox, Mylanta. We go easy to start with, and we could add on into any of the medications we use in adults. Now, sometimes this reflux is so severe and that esophagus is so burned, we need to do a surgical intervention called a Nissen fundoplication. This basically ties the stomach up over the esophagus and it prevents that vomiting from going up and continually burning the esophagus. So Nissen fundoplication is severe to do it, but it does save the esophagus. So the other type of vomiting is pyloric stenosis. This is the one with an olive shape in right underneath the xiphoid process. I call it a marble olive. It's a round something, and you can feel it. It's actually the hypertrophic pyloric valve in the stomach, okay? The difference between vomiting in infants and pyloric stenosis is this food goes down, gets in the stomach, and the baby eats and is all happy. And then all of a sudden, point the child at a garbage can 10 feet away, and they will projectile vomit and they'll hit the garbage can. It is the most impressive vomit that you will ever see. So, what do? Well, we don't want to feed this kid anymore. We don't want any chances of them aspirating. So this child is NPO. Now, infants, these are usually 3 weeks to 3 months old, pyloric stenosis. These are your young infants. These children do not tolerate being without dextrose fluids for long periods. So this child will be on an IV and only NPO. They're not going to aspirate. There's nothing left there. Okay, so it's only NPO and IV fluids. Now, hepatitis. Now, what is hepatitis? It's an inflammation of a liver. What does the liver do? It produces bile, which does what? It digests fat. So if you have a problem with your liver, you're not getting the fat you need for digestion. You're going to have problems with fat overload, which causes gastric distension, bloating, and a lot of gas and a lot of abdominal discomfort. Okay. So these children, what are the big things with it? Well, number one will always be nutrition, 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 right? We got to decrease the fat. All right. They're not digesting it. The liver's not giving me bile. It's not working. So, high protein, high carbohydrates, because fats hold a lot of calories. And that child still needs a lot of calories to be able to grow it the way that they should. As the kid gets older, looking at types of foods, meat, fish, fruits, vegetables, and milk. And I would say a low fat milk, of course. These are things that are good choices for that child. Now, another nutritional issue is what we call celiac disease. Celiac disease is a problem with dietary gluten, which is in wheat, rye, um, barley, and oats. Okay, they say it's not so much in the oats, but they are all the cross contamination. They just say not to go for it. What happens in the celiac disease is that the body cannot digest fat again. So if you give them fat, they're going to get abdominal distension, they're going to have diarrhea, and they're going to have something called steatorrhea, which is this fatty, bulky, oh, and it smells horrible, malodorous stools. So you're getting rid of all your fat, in your stools, okay? You're also losing all your fat vitamins out that way too. So, what would be a great substitute for this child? Well, rice would be something that we would introduce. They have rice breads and rice everything today. So, we're good that way. Give me 1 second, please. Thank you for your patience. That was my doctor. I had to talk to him quickly. Okay, so steatorrhea, we're getting rid of all of our fat, right? So we have to make sure that we don't overdo fat on them. Again, increasing protein, increasing carbohydrates. And then, of course, you have to worry about all the vitamin deficiencies on this child. And it is a lifelong condition. So, food allergies, these happen, right? We do our food checks, right? At 6 months, we start one at a time, every 4 to 7 days, making sure they're not having allergies. Remember, if they have allergies to a certain food, that means they're lacking that vitamin, whatever that is giving them to the body. So, let's say your child is lactose intolerant. Make sure, are we giving that child vitamin D and calcium in different ways? That is what we need to be concerned about. If we have a child who is having problems with bones and healing, well, we're going to increase protein. Remember those things in food and how we use it to better the body. Now, Hirschsprung's disease. Hirschsprung's disease is when the descending bowel, it's pink, it's alive, it's there, but it has no nerves in it. And what does that mean? That means it can't peristalsis and squeeze food and content so it can come out that little tiny little tube out the anus. This is the condition where sometimes a little bit squeaks out of there, out of the anus, and it's ribbon like. It's like coming out of a frosting tip because it's so tiny, and that's about all you see there. This is a piece of stool, a bowel that has to be removed. It's going to cause a bowel obstruction because it doesn't move the contents down. Okay. And it's going to keep getting bigger and bigger. This is another one. No bowel movement at birth up to 36 hours later, right? This is going to need either a colostomy or it's going to be needing a pull through procedure. Okay. Which means they take this end, cut out the piece, and they can attach it. It's called pull through and attach it. Many times they can't, depending on what's left in there, and then they have to do a colostomy. And they just, do that. They try to close it up before potty training. What do we know about Hirschsprung's disease? This is something to do with the intestines. So we don't want to post-operatively touch the intestines, no rectal temps. We want to rest the intestines. They should be NPO for a couple days and then slowly increase the diet, clear liquids, and see how the food goes through that intestines that's just been manipulated. So pinworms, enterobius. This is the children going outside playing in the dirt, getting little pinworms, little eggs up the little nails, and they, put it in their mouth and they eat them and they hatch inside. And now they're crawling out the anus and creating the most intense perianal itching and scratching. And it usually happens when it's dark at night and it keeps them awake. We go in with a piece of scotch tape and a flashlight and get a piece of worm, bring it to the doctor. Now, if your child brought home pinworms, check the entire family. Probably the family has worms at this point in time. And how do we prevent this? Simple. Washing hands, that always has to be number one, but cut the nails short on that child. Now, esophageal atresia, tracheoesophageal fistula. This is a very similar condition, and the treatment's very similar to pyloric stenosis. Okay. They both have to do with a problem with eating, but this one's more severe. Esophageal atresia, tracheoesophageal fistula means when you swallow, it either goes down to nowhere and comes back up, or it goes down the esophagus across that fistula, that connection to the trachea, and it goes into the lungs. And now you're gagging, choking, aspirating. And this is a child, that's what you would see at birth. These children will even aspirate on their own mucus because they're swallowing their own saliva, going down the esophagus, across the fistula, into the lungs. So, how do we treat tracheoesophageal fistula? Well, head of the bed elevated, and we want suction there just to try to keep the mouth clean, all right? Remember, our big thing here is prevention of aspiration pneumonia. They swallow, it goes down into the esophagus, into the trachea. It goes down the esophagus, there's no connection to the stomach, and it comes back up, and chances of aspiration. So, this child is like that pyloric stenosis, NPO, and IV fluids. The difference with this one is because of the chance of many aspirations, this child will get IV antibiotics for those prevention of aspiration pneumonia. Another thing with this case in growth and development, and this is a perfect one, any child who cannot eat, suck normally, which they can't, give them a pacifier. This is how they can comfort themselves. And again, it's self-soothing. Appendix. You have an acute appendix, just like adults, McBurney point, right lower quadrant. We get them do an ultrasound, and what do? Well, preoperatively, this child, you're going to know it's an appendix. Right lower quadrant, they're holding their right lower groin. They usually walk in bent over, limping on their right leg. Oh, that's an appendix. You can tell. So immediately tell them nothing more to eat or drink. They'll do the ultrasound, they'll come back, say, yep, it's an appendix. You start an IV and we'll start prophylactic antibiotics. That's an infection, an itis, it's an infection. So we want to give that antibiotic. Also, any pre-op meds they need to take, they can take preoperatively. Now, postoperatively, the appendix burst, and now you have a peritonitis. That means all of those contents has gone into the peritoneal cavity and is creating havoc with the organs and the intestines. So, how do we treat it? What's our priority here? Well, it's an infection. Antibiotics, priority. NPO, you need to rest that tummy there, okay? Not only rest it, you're going to have an NG tube in to prevent that nasal juices, the gastric juices, to get down into the GI cavity and create havoc in there. They don't even want that to go through because it will cause a lot of irritation there. So, antibiotics is priority. NPO with IV fluids, you got to maintain that. As a nurse, you'll be monitoring lab values. What lab values are you monitoring? Well, it's an infection. You're going to be monitoring the white blood cell count. Are they coming down every day or every time you do that CBC? Of course, pain control is very important. These children need to be turned and coughed and deep breathed and getting out of bed and ambulate. You need to prevent problems with their lungs and problems, with even thrombophlebitis. Children do get these things, believe it or not. And one of the things we tend to forget, and I saw it once, so I will never forget it, on an appendix that's burst with a peritonitis, they've closed the wound up, but the inside was all, quote, dirty because it burst in there. That infection was there. So it's not a good, clean wound. The chances of that dehiscing are great. So make sure you assess that wound. And then I use all different tricks to help my children keep their lungs good. One of them's blowing a bubble, having bubbles out. Child Life always has that good stuff for me. Or one of those pinwheels that you blow. Older kids, I actually would actually go to the cafeteria and get straws, and we do spitballs at 3 o'clock in the morning. And those kids' lungs would never be bad when I was on duty, and we would have fun doing it. Now, omphalocele gastroschisis, bladder exstrophy. These are all conditions where the inside of the body was born on the outside in a sac. Okay, whether it's abdominal contents or a stomach or a bladder, it's all basically the same care. Number one, you need to cover it with a wet, sterile, normal saline dressing. You must maintain the skin integrity. We've got to close that up soon, right? We keep stuffing it in. The surgeon comes every day, keep stuffing it in. They pile it up and keep making sure there's room in there. This child, you have to leave them open on a warmer. You need to be looking at that abdomen where that is coming out of their abdominal cavity. No swaddling. And we're going to have them on antibiotics prophylactically to prevent infections. This child will not eat until this all is put back in there. And of course, they'll be on IVs. Meckel diverticulum is basically a little skin tab in the small intestines. And in that little skin tab are big capillaries that sort of swell and they rip and they tear. And it causes just bleeding to occur in the small intestines. And you see painless rectal bleeding. When they find it, they do this x-ray procedure where they go in with radionuclide and they find it, they do surgery, they take out the diverticulum, and they do well, period. Now, nephrotic syndrome. Again, this is not renal failure. The kidneys are working. The kidneys are good. They're just pumping along and doing what it's supposed to do, except it doesn't like protein. So the kidneys are doing what they need to do, but when protein comes along, they say, oh, I don't like you, and they urinate all of the protein out. Now, protein and albumin are the same name. So we've heard of albumin in the blood, right? That's the protein where medications hop onto, and then you have the free medications in there, right? So proteins are important for medication administration. So we don't want that protein to be that low. And because of all the protein being gone, fluid tends to go interstitial, which means you got all of this swelling going on all over, generalized edema, because of the way that the blood now just pushes all the extra out into the tissue. So it's a fluid balance problem, right? Fluid balance problems, what do you monitor? Daily weights, intake, output. And because it is this massive swelling, we're going to have salt restriction, fluid restriction, and these children are immunosuppressed. You really must be taking care of preventing infection for them. Now, acute glomerulonephritis is acute, which means it happens because of something. Well, it happens because of a strep infection that was not treated or not treated completely. And what do you see with acute glomerulonephritis? Well, you stop urinating, so fluid goes somewhere, so you're swollen, edema everywhere. It's the kidneys again, so blood pressure, worry about it. And glomerulonephritis is periorbital edema. Okay, we had generalized, right, with your nephrotic syndrome. Acute glomerulonephritis is just periorbital. Okay, when we have a child with a kidney problem, a good acute glomerulonephritis, know that you're going to be monitoring blood pressures really closely. Know that these children can stroke out from very elevated blood pressures, so monitor it, the blood pressure closely, because they're just trying to squeeze whatever urine out. There's going to be blood in it. So you see hematuria. Also, depending on how long this has gone on for, you're going to see protein in the urine. It just has to do with how long has this been, festering with a strep infection causing this acute glomerulonephritis. So again, this is a fluid balance problem, right? Intake, output, daily weights. Low sodium diet, fluid restrictions, susceptibility infections, just like nephrotic syndrome, just the periorbital versus generalized. Very similar nursing cares. So renal biopsy, we do these sometimes to figure out if there's a tumor or infection, something we're not finding. It's very similar to what we do for cardiac casts, believe it or not. So NPO before they go, and basically when they come back, you're going to be checking the dressing, and their kidneys are on their back. So you're going to be looking at the dressing on the back, which has a nice, good pressure dressing there. We're looking for urine, we're looking for blood. We're also checking the abdomen for tenderness, because that could be blood or urine going in there. Because it's a kidney, you're going to be monitoring intake and output on these children. And these children are in bed for 24 hours. We don't want to blow the clot off the kidney and cause urine and blood going into the peritoneal cavity. So 24 hours bed rest. Renal failure, another, it's a fluid balance problem, right? So again, what are we as nurses monitoring? Well, we're going to monitor their fluid electrolytes, intake, output, daily weights. Also, it's a kidney problem, so this one is not producing erythropoietin normally, so we can give them those subcutaneous injections, and that's going to help with their hemoglobin hematocrit. They're going to have less transfusions because their body's doing what it can. And again, any condition with children, no matter what it is, you always try to let a kid be a kid. Promote a normal and active life as possible. Now, peritoneal dialysis. We're using this also in your adults today. Usually it's actually your first line they're going for now, instead of right for the hemodialysis. Now, young children can't do hemodialysis because of the blood flow that goes in and out and their brain and the fragility of vessels. It will cause strokes to occur. So we don't do hemodialysis on the young kids. So what we have is that catheter, and it's a sterile procedure because you have one kidney, which is an abdominal cavity. That's all you got. So you've got to keep it as infection free as possible. So what do you think we're going to be monitoring? What's the most important? We're going to be monitoring the drainage, the fluid color. Has it changed? Looking at the abdomen. Is it reddened? Is it painful? All of those things are going to tell us there's a problem. And what do we need to do if we see any of those things going on? We're going to call the doctor and we're going to get antibiotics ordered. So scoliosis, S-shaped curvature of the spine. Know that this is that pre-adolescent growth spurt where we see this a lot. Body image is the big thing, right? With adolescents. So this is a disturbed body image for these children. Now, scoliosis, our concern is where that curve goes into the lungs and prevents the lungs from expanding. So you don't have complete lungs to be able to breathe on because one's being squished. So when they find scoliosis on these children and it's less than 45 degrees, they will do very conservative treatment. They'll put a brace on with a cotton shirt underneath, so it's no rubbing going on there. And we leave that on 23 hours a day and we give them physical therapy, strengthening the muscles. And sometimes we get that spine pretty well back, where it needs to be. It'll never be perfect, but it'll be better than what it was. We only take it off 1 hour a day just to bathe, to make sure that we check the areas for any breakdowns. We don't put lotion underneath there, powder underneath there. I mean, we can rub the areas, massage it, making sure that there's no redness, etc. But we're not going to do that lotion powder there. Now, hip dysplasia. Babies are born and that hip joint, that femur doesn't go into that hip joint well. It's up here somewhere. And it could be anywhere from here all the way to the top. So, what are you going to see in these children? Well, number one, this leg is going to be shorter because this leg was pulled up the ear. So that's that one shorted leg on the affected side. You're going to see the buttocks, the gluteal folds. One is going to be higher than the other. Positive Ortolani, positive Barlow. And what we're going to do on these children, because their bones heal very quickly. That's this week's lecture. It's 2 to 3 weeks we can heal a bone on a neonate, the first 28 days of life. So as quick as we can, we put on a Pavlik harness. Again, 23 hours a day, cotton shirt underneath. And we're going to be checking their skin for breakdowns and massage those areas underneath the harness when we take it off that 1 hour a day, just to keep that skin good on those children. Now, sometimes we can't get that hip back to where it needs to go, and they need more sort of traction. The top picture is Bryant's traction, and that is up to 30 pounds of a child. Over 30 pounds, we can't use it. So it is a right angle, the buttocks a little bit off the bed, and it holds it in the right angle, and that's also used for hip dysplasia. Types of fractures, simple or closed, normal ones. These are the kids fall down, it swells, but there's no bones through the skin. The open one is like the picture where a bone comes through the skin, and now you've got the bone out into the world, it's getting infected, and you worry about osteomyelitis. So this one requires IV antibiotics because we want to prevent that osteo. We've got complicated. I call this the one that we fracture a rib and then a rib goes through a lung and that damages the other organ. That's a great one to use as an example. Comminuted is when the bone sort of shatters into little pieces, and all of those little pieces can be very irritating. An avulsion, the bone is pulled away from the tendon or ligament. It's like a really, really bad sprain, and it really hurts. And then we have what we call spiral fractures. It's when you take an arm and you twist it and pull it. We see this a lot in child abuse. So the types of traction, we've already talked about Bryant's, what it is, right? Congenital hip dysplasia. We're going to elevate off the bed a little bit. And the other one here is Buck's traction or Russell's traction. They're very similar. Russell's just has that extra piece up underneath the femur, the upper thigh. But the big thing about traction is you have to have those weights hanging freely because you want that bone, that femur bone, to be approximated, and you let it hang there and you never take off the weight because you take it off, it's going to move those bones and cause a lot of pain. So, again, keep those weights hanging freely and it's always on, you never take them off. If you have to have a cast put on a child, know that we need to teach them and we need to do these assessments. We need to check for pain, pallor, pulselessness, paresthesia, paralysis, and pressure. These are the basics of checking, making sure a cast isn't too tight. Cast care. Oh, we need to keep it dry. I can't tell you how many kids ran home after getting a cast on their arm, put on their bathing suits, and jumped into the pool. I had one kid did it 2 times in 2 days. The mother was about to kill the child because, not really, but that the kid had to go back and get another cast put on because they cannot be wet. So they need to have that cast elevated, wiggle the toes. Again, no lotion, no powder, nothing needs to be stuck in there. And the best way for that itchy that goes on is a cool hair dryer. So cerebral palsy. Cerebral palsy is a impaired muscle movement, hypertonicity, and poor posture. And it's something that once you have it, you're not going to come back from it. You've just got to give that child everything they need to be as independent as they can. All right. Know that cerebral palsy, and one of the basic things is problems with lack of muscle control. One of the big things is feeding these children. Okay. They don't necessarily chew and swallow like we do, they take a longer time. So keep the head of the bed elevated. Give them that extra time and know that biggest concern is aspiration on these children. So children, these sort of children, worried about them and taking care of them. Dental hygiene is important because of the anti-seizure medicines they might get. Again, those safety precautions, full risk, and of course, feeding problems with them. And again, early intervention, physical therapy, speech therapy, occupational therapy. Know that you're still going to have your dosage calc. You've got a worksheet that I sent out to everybody. Guys, it's been a pleasure. I hope you all do really well. I hope that I can help you, by the way, explain things. Good luck.
Thank you. I appreciate it.